Hello and welcome to another emergency questions and answers for families in intensive care and intensive care at home. Thank you for joining today's call, and also a warm welcome to everyone being live on the call, and also thank you for anyone watching this on replay. We get a lot of views on replay. I've seen that for last week's emergency questions and answers for families in ICU and intensive care at home. We had around 120 replays, so thank you so much for that. Now, before I go into today's questions that I can already see in the chat pad, what makes me qualified to host an emergency questions and answers for families in ICU and intensive care at home? My name is Patrick Hutzel. I'm a critical care nurse by background. I have been working in critical care nursing for over 25 years in 3 different countries, where I worked as a nurse manager for over 5 years in intensive care and critical care. And I've been consulting and advocating for families in intensive care since 2013 here at intensivecarehotline.com. And I can very confidently say that we have saved many lives for our clients and members over the years. We have helped hundreds and hundreds of members and clients over the years here at intensivecarehotline.com. And you can verify what I'm saying is accurate by just looking at our testimonial section at intensivecarehotline.com. And you can also look up our intensivecarehotline.com podcast section, where we have done client interviews. We also have a membership for families of critically ill patients in intensive care. And you can become a member if you go to intensivecarehotline.com, if you click on the membership link, or if you go to intensivecaresupport.org directly. I'm also the founder and managing director of intensivecareathome.com. With Intensive Care at Home, we are providing a genuine alternative for a long-term stay in intensive care, predominantly for long-term ventilated adults and children with tracheostomies. We send our critical care nurses into the home 24 hours a day, and we replicate an intensive care bed in the community for, once again, predominantly long-term ventilated adults and children with tracheostomies, but also for home BiPAP, home CPAP, home tracheostomy care without tracheostomy, without ventilation, home TPN, home IV magnesium, home IV potassium infusions. We're providing port management, central line management, Hickman's line management, PEEK line management. We are providing management at home for nasogastric tubes, for PEG tubes. We're also providing palliative care with Intensive Care at Home. We are currently operating all around Australia, in all major capital cities, as well as in all regional and rural areas where NDI is approved, TIC and WorkSafe in Victoria, iCare New South Wales, as well as NIISQ in Queensland, and DVA all around the country. Our clients have, and we as an organization, have also received funding through departments of health, public hospitals, and private health funds. Now, before I answer today's questions, if you like this video, if you want to support what I'm doing, subscribe to my YouTube channel for regular updates, click the like button, and leave comments and let me know what you want to see next. Now, without further ado, I've got questions here from Leanne Owings. Leanne, thank you for joining, and let me answer your question. So Leanne says, hi, my dad has been out of a coma on 35 to 40% of oxygen, on 30 of PEEP for 70 hours, sits out of bed 4 hours a day. Talking about moving dad from ICU to ward, also everything drops when he is helped into a chair. His feeding tube was removed today. Is there hope for my dad? Thank you for any help. He's 67, was admitted to ICU with pneumonia. They also said he had a misdiagnosis, ILD fibrosis. Okay. And ILD fibrosis, I just quickly do need to Google the term. Interstitial lung disease, sure. So it's got interstitial lung disease. Okay. So, Leanne, what I don't understand is, out of a coma, is he still ventilated? Now, if he's on 30 of PEEP, he would be ventilated. However, I very much doubt that he's sitting out of bed on a PEEP of 30. A PEEP of 30 is It's almost not possible. The highest PEEP that I've probably seen might be 20 on very, 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 very rare occasions, and only if a patient is, generally speaking, deeply sedated and paralyzed. Now, that is not what you are describing here, Leanne. I'll give you another tip. I think I can answer your questions much quicker if you join me here live on the StreamYard link. Click on the link that I just posted there and talk to me directly here. I do believe we can nut out your questions much quicker and also clarify much quicker. I just thought the noise, I might be wrong with that. Yes, he can't be on a PEEP of 30, not sitting out of bed. It's impossible. Right? Leanne also sits out of bed 4 hours a day, talking about moving dad from ICU to ward. Also, everything drops when he's helped into a chair. His feeding tube was removed. What do you mean by everything drops? What do you mean by that? Can you be more specific? Can you be more specific, please? A lot of it also depends, Leanne. Okay, it's now on CPAP. Okay, it's now on CPAP. A lot of it also depends. How long was he in an induced coma for? Right? How long was he in an induced coma for? Was he in an induced coma for a couple of days, for a couple of weeks, for a couple of months even? You know, like his oxygen and blood pressure. His oxygen and blood pressure drops. Okay, all right. So, the interstitial lung disease fibrosis, has that been a recent diagnosis, or have you known about that for quite some time? Is that a new diagnosis? Or was the interstitial lung disease and fibrosis diagnosed on this hospital admission when he was having a pneumonia? 2 days off for 12 hours, back on for 42 hours. So I presume you are now referring to the induced coma. That's not very long, which is good. Yes, it's a new diagnosis. Okay. Okay, so this is a new diagnosis. Okay, so the question here, Julie, is, Leanne. Question here, Leanne, is, with an interstitial lung disease and fibrosis, depending on the severity of it, right, what that basically means is the lungs will be very stiff going forward and they lack compliance, right, because there's going to be developing scar tissue in the lungs, or potentially scar tissue has already developed in the lungs with interstitial lung disease and fibrosis, right? So the question here is, what's next with the fibrosis? So what is next with the fibrosis is patients often end up on consistent oxygen, and also patients, sometimes not all the time, end up on a lung transplant list, right? So is your dad qualifying for a lung transplant, right? But it also sounds to me like, your dad is on a good trajectory right now. He's on a good trajectory and he is, doing what he's supposed to be doing. Just scrolling back in your comments, out of bed 4 hours a day. How many days has your dad been out of hospital? How many days has your dad been out of a coma? How many days has your dad been off the ventilator? Leanne, if you could please answer that question, because again, my answer depends a lot on that, And like I say, if you want to join me here and talk to me directly, I do believe we can get to solving your issues much quicker. Tara, I can also see that you are here. Tara, I will get to your questions very quickly. Tara, the same for you. If you wanted to talk to me here directly, just click on the StreamYard link and I can get you here on video. You don't need to go on camera, but we can go and talk here directly, which is much quicker and much easier rather than texting back and forth here. We're still working days before admission on billing side, 2 days out and off vent, 2 days out and off vent. So it's been, okay, it was ventilated for 2 days and in induced coma for 2 days. Okay, not a long time. So that's positive that he came off the ventilator after 2 days. That is very positive, right? So what they need to do next, as a next step, Leanne, is they need to look at lung function tests. They need to look at chest x-rays, CT scans of the lungs. Yes, Tara, I think that's a good idea. If you can join after I've answered Leanne's question, I think that's a good idea. Need to look at lung function tests, CT scan, MRI scans of the lungs, and then determine what's going to happen from there, right? And that might be a lung transplant. Okay. So, but I think 2 days on the ventilator and being off the ventilator after 2 days for pneumonia plus lung fibrosis, I think that's a pretty good turnover, right? I've seen patients with lung fibrosis or interstitial lung disease being confined to a ventilator for many days, many weeks, and they end up with a tracheostomy. So that is a positive sign that your dad came off the ventilator after 2 days. Okay. So I hope that answers your questions, Leanne. Tara, if you want to join now, I think now is a good time so that we can hopefully look at your dad's situation. Just click on the link. Do you want me to post the link again here, Tara? I'll send it here again. Just click on that link and then I should be able to let you. He did go back on for 2 days after 12 hours. Okay, still. He's off the ventilator now and he's mobilizing. You've got to look at the positives here. Got to look at the positives, you know. He's off the ventilator now and they're talking about him going to a ward. That's a good sign. He just needs to, you know, you just need to make sure he stays there. You know. You just need to make sure he stays there. Okay, I can see Tara is joining here. Hi Tara, how are you?
Hi, good. How are you?
Very good. Nice to see you.
You as well.
I'm well up to date with your dad's situation. I'm well up to date. What are your burning questions on top of the emails that we've been sending you?
So one, I feel like I have no rights, or they might be being violated. They put him on a psychotropic without my permission. They've just been kind of just moving real fast paced and not informing me of stuff. And as a decision maker, I feel like I should be informed of a lot of stuff to make appropriate decisions. So then they pretty much had a meeting to tell me, because you know I've been thinking I'm advocating for my dad, and they told me you have no say. Like, we do what we want, pretty much. And I can see that they're starting a paper trail of, you know, me and, you know, how they don't like me advocating for him. And so then they said that they're going to take him off of ECMO Monday. And I said that I'm not comfortable with it. I don't feel, I understand. I feel like they gave him 7 days. If he didn't wake up, they weren't going to do the transplant. And so now they're saying there's no need for the ECMO because he doesn't qualify for the transplant now, just because they gave him the 7 days, but they're saying organ failure and everything else. But I just haven't done my research or look up other options, and I'm not comfortable with it. And I told them I'm not comfortable with it, and they said they're doing it regardless. They're taking him to the operating room and doing the last test and removing it. And I've considered calling the state at this point because I just feel like I just have no say in anything and stuff. So, yeah.
Okay, couple of questions there, Tara. I can't remember when we last spoke. Are you the power of attorney?
I'm my sister, my dad signed my sister as the power of attorney,
Okay.
but they supposedly voided it, and so to make me the surrogate decision maker.
You are the
Um
surrogate decision maker. Okay.
yeah. So then because originally my sister said she doesn't even want it. She doesn't feel comfortable being the power of attorney and wanted to pass it to me. And so they just decided to avoid it and,
Yeah. Okay.
assign.
Okay. All right. Look, the first thing here, Tara, that I want to say is, you're doing an amazing job advocating for your dad.
Thank
We
you.
can see that. And just because they don't like it or they potentially keep a paper trail or whatever they do, are things you can't control.
Yeah.
Right? Just focus on the things you can control, because you're wasting your time worrying about the things that you can't control.
Yeah.
Right? You're completely wasting your time.
Yeah.
As far as I can see, I think you're doing an amazing job advocating for your dad. I think when I look at the reports, your dad is slowly but gradually improving. Now,
Okay.
whether he'll be ready to have the ECMO removed on Monday, I kind of doubt when
Yeah.
I look at the numbers.
Okay.
So let's just say they were going ahead with that. What are they telling you in terms of, are they telling you, oh, if we take him off ECMO on Monday, he's going to die? Is that what they're telling you?
No, they're saying he has a 60% chance of doing well and a 40% chance of not doing well. And then when I told him, okay, well, I'm still not comfortable, they said, and he'll be on the Impella, which will be assisting temporarily, but they're going to just go ahead and remove the ECMO.
If they put him on the Impella, that might be what keeps him going, right? As long as they have a plan, right? A lot of patients do end up on an Impella after ECMO is removed.
He's currently on the Impella as well.
Oh, is he already on the? Yes, that's right. Yes, no, you're right. You're right.
Yeah.
He's okay. So that means they can probably safely do remove the ECMO, right?
Yeah.
So, do you know if the Impella is for the left side of the heart or for the right side of the heart? I do believe it's for the left side of the heart.
The
Do you
left
know?
side. The
left
left
side.
Mm-hmm.
Yeah. So from that perspective, they can take him off the ECMO,
Okay.
right?
Mm-hmm.
But the question is, what's their plan afterwards?
Right. Exactly.
That is the $1 million question. Now,
Yes.
also before we look at that, Tara,
Mm-hmm.
they are talking about multiple organ failure. The lungs seem to be fine.
Mm-hmm.
The heart's not.
Mm-hmm.
The kidneys are not.
Mm-hmm.
And the brain's not. So, they will probably try and continue talking about multiple organ failure, which to a degree is accurate,
Mm-hmm.
right? So heart's not working, i.e. he's on ECMO and needs to continue on the Impella. Okay, we can't deny that.
Mm-hmm.
The brain's not working at the moment. We can't
Mm-hmm.
deny that. The kidneys aren't working. We can't deny that. So have they sort of focused on, oh, he's got multiple organ failure? Is that what they're saying to you?
So they're not. With the brain, he's now squeezing hands on, not continuously. He'll do it in a row and then he stops. But then he's also doing this type of posture. So one doctor noticed that, and then the cardiac doctor came in. He didn't squeeze for him, and then he noticed the type of posturing, which he says is indicative of brain damage, where his hands are going out and he arches his head back, and it doesn't hold. Like when I did my research, that a lot of it, they said that the hands need to be clenched and hold, but like not holding, it's not as severe. So he probably does have brain damage, but probably not. But I don't understand why they were excited about him clinching on demand if they're saying he's severely brain damaged. So I don't know. It's kind of.
So when you say he's squeezing hands,
Mhm.
is he only doing that for you or for your family, or is he doing that?
So from what I've seen, like as his like reflexes and stuff have been coming back, they don't start every time. They start with we'll see it first, and then it'll be consistent and the doctors and nurses see it. So for a couple days ago, I felt it, my aunt felt it, my cousin felt it, and then just today, two doctors and the nurse last night felt it. So it's happening more often, like as the days go by. So no, some providers have seen it, but it's still, they're still saying it's not purposeful because it's not every time.
Not every time, but you have seen it to be purposeful.
It's on demand. Like you'll tell him and he'll do the hand that we don't even tell him which hand we're holding, and he'll do the hand that our hand is in.
Yeah.
So yeah.
So okay, so that's that. And
Mm-hmm.
as far as we can see in the reports, he's also still on sedation.
So back to the sedation. I had researched that Ambien had paradoxical effects. And so neurology gave me the okay to try it, but they dosed it not the way I wanted to, because it was supposed to happen within like an hour. And so then I said, if it doesn't do that, so when we gave it to him at nighttime, he went to sleep. At first, his eyes were always open. When we gave him the Ambien, he slept through the night. And then the next day he was more aware, more like agitated. And, so then they started to give him fentanyl. They started to do a lot more other things. And I told them, I don't want him on any sedation. I feel that when I researched it, it said that is a sign of neurological recovery. And he's clenching, like he's more aware. And so they had a huge meeting with 15 people, including ethics, risk management. And they told me they are going to sedate him for pain. I said we could try sedating pain medications if that was your reason to sedate him. I don't want him sedated. They said they're going to continue regardless. It's not up to me. And so then they continue to keep him on the Precedex and the fentanyl, and yeah.
So I can't see in the notes that he's on fentanyl. I can see the Precedex. I can't see in the notes that he's on fentanyl.
Okay. They have it as needed for the nurses to use when they feel. Yeah.
Do you know?
And I had a nurse come in and see him turn his head, and she goes, "Oh, not tonight, fentanyl." And she went in. I told her, "No, we're not doing fentanyl." And that's where this whole issue of sedation came about. So.
Right. Okay. So here's the problem. It's a very fine line here, Tara. There's a very fine line between keeping him comfortable with the breathing tube, right, and taking him off sedation so that he doesn't get agitated and potentially fights the breathing tube, but also fights ECMO. And also, once he's off ECMO, fights the impeller.
Okay.
Right? So I can see that dilemma. And one of the dilemmas here is also how do you assess his brain function if he stays on sedation? Right? So it's a very fine line. It's a very fine line here.
Yeah.
And your dad is still on a lot of support from the ECMO, and hopefully he can keep improving. And hopefully he's improving to the point where they take off ECMO and they continue with the impeller. Then they can focus more on ventilation weaning. And they can also then focus more on removing sedation completely. So let's just say ECMO was off. Right? No ECMO, no impeller. I would say stop sedation, wean him off the ventilator as quickly as possible.
Okay.
If they take off sedation and he's potentially getting too agitated, potentially getting combative, then it could impact on the ECMO therapy. It could impact on ventilation therapy, right?
Yeah.
So do you know if they've stopped sedation completely during all of this?
At a point, they did until we gave him
Okay.
the Ambien, and the next day he was super agitated and, yeah. So then they started the continuous Precedex, and yeah.
How long ago was it when they stopped sedation?
Prior to that, they stopped it 24 hours after his cardiac arrest.
Okay, and then
They gave him till 1 week from his cardiac arrest. And then that's when they were like, he's no longer qualified. And that's when I was like, let's try Ambien. We're at the, you guys already counted him out. And then he started becoming more awake and, restless and stuff.
right. Okay.
Yeah.
Okay. And you've seen it yourself. You were there.
Yeah. I've
Right.
the agitation. Yeah, and it was pretty bad. He was biting on his tubes very, like, to the point he was suffocating himself, because he's a very, very strong man, and he was like trying to like get it, like he was, but the doctors like that was at nighttime, and then in the evening, and then when I talked to him about, when they were talking about he's just uncomfortable with the ventilator, then I was asking like, can we try and wean him off of that either, and they're like, no, because of his scale so low, so they don't. But I was like, if they're like, if he's more awake and they see that more often, they would be comfortable, but they don't. He's now on sedation, they'll never see it, so I was like,
yeah. So the positive that I can see with him getting off ECMO on Monday is that it will be easier for them to then focus on taking off sedation and focus on ventilation weaning. Right? So at the moment, you got to picture this. Here's one of the issues. The ECMO is more or less taking over the function of the heart and of the lungs as well to a degree. He's on 100% of oxygen from the ECMO. So the air that you and I are breathing is 21% oxygen. Right? So we are breathing 21% oxygen in the air. He's on 100% of oxygen.
Wow.
Once ECMO is off, he's getting 40% of oxygen from the ventilator at the moment, right?
Yeah.
So the benchmark will be 40% of oxygen from the ventilator once he's off ECMO. The goal will be to gradually wean off the oxygen levels.
While he's on the impeller?
While he's on the impeller.
Okay.
While he's on the impeller, absolutely. Okay. And then also wean ventilation down. At the moment, the ventilator is doing most of the work. Okay. So it's not doing a lot of spontaneous breathing at the moment, right? We can see that in the reports.
Okay.
So once he's off sedation, or sedation is being weaned off gradually, right? He should then be starting to breathe more and more. Okay. Right? And that's how they gradually will wean him off the ventilator.
Okay.
Right? Those are his next steps.
Should I advocate for that, even if they tell me that his cognitive level is low? Because that's their main reason why they'll never try to wean him off, because of he's not doing anything on command. So.
You mean they will never wean him off the ventilator?
That's what they told me. They said he's not coming off the ventilator until he's doing things on command, until his some score goes up. And they have him at the lowest, saying everything's non-purposeful and he won't protect his airway. And so that's my struggle, because I'm like, he's progressing, but they're not giving him time to progress to increase that score to get to that point.
And this is why they're not telling you the full story here. So let me tell you, I believe, what is the full story here.
Okay.
So at the moment, he's breathing on 16 breaths per minute that he gets from the machine every minute. Okay. He's on 40% of oxygen. He's getting a volume of 450 mils per breath. He's on a PEEP of 5. So that's fairly standard for someone that is in a coma. So I still argue that as soon as he's off ECMO, that he will automatically wean off the ventilator once he's off sedation. I think it's almost an organic process. They can't stop it.
Okay.
They can't stop it. Now, here is where the issues might come in, though.
Okay.
I agree that if he can't wake up, or if he doesn't wake up with purpose, he might be unable to protect his airway. Right. He might. That might be an accurate prediction.
Right.
However, here is where we need to make a distinction. Let's just say he can wean off the ventilator, but he can't protect his airway. That's when a tracheostomy might come in.
Okay.
Do you know what I'm talking about with the tracheostomy?
Yes.
Okay. So that's where a tracheostomy might come in. It's not there yet. And I'll tell you why it's also not there yet. And this is where, what I keep saying to clients, when someone is in a situation like that, there are so many things happening simultaneously and so many things that need to be considered. He is not a candidate right now for a tracheostomy, and here is why. He's on heparin. Heparin is a blood thinner. He needs the heparin for the ECMO. If he's not getting heparin through the ECMO will clot, and he is at risk of dying because of another cardiac arrest. He's at risk of a stroke.
Yeah.
Multiple risks.
Right.
Now, but because he's on heparin, he's also not a candidate for a tracheostomy right now because of the risk of bleeding.
Okay.
Because heparin is a strong blood thinner. Right? Yeah. The minute, and this is where I'm trying to paint the picture for you and project what's going to happen next. The minute he's off ECMO, right? That's one form of life support taken away. He goes on the impeller. He will still need heparin on the impeller.
Okay.
Right? But they might be able to stop the heparin for 24 hours and do a tracheostomy. They might. It is much more likely. Much more likely. But that is only if he can't protect his airway. So let's just say he's off the ECMO. They stop sedation. He's waking up more and more with purpose. And all of a sudden, he might be at the point where, okay, hopefully his brain is working, and people can actually talk him through weaning off the ventilator, because it helps if you can talk someone through it. Right?
Yeah.
So then, best case scenario is he can wean off the ventilator, avoid the tracheostomy. That's the best case scenario. Worst case scenario is he can't wean off the ventilator, he's not waking up, and then ends up with a tracheostomy on a ventilator. So that would be the picture they are painting.
Okay.
Right? Because if he can't wean off the ventilator, he can't stay with a breathing tube forever.
Right.
Right?
Yeah.
But he will have to overcome that hurdle with the heparin.
Okay.
Right?
Yeah.
So it is a very complex situation, Tara. It is a very complex situation, as you can see. The answers are different scenarios.
Yeah, for sure.
Right?
Yeah.
And the other thing that you got to keep in mind, when someone is on ECMO in ICU, they're at the highest form of life support in ICU. Yeah. Your dad would be one of the sickest patients in that ICU right now.
Yeah.
Would be one of the sickest patients. Not many patients in there would be on ECMO. There would be some, but not many.
Yeah. Yeah, they've told us that.
Right.
Oh,
So that is what I'm predicting here. The other question that you should ask is, with the impeller, that should go into an LVAT. Have they talked about that?
They says he can't do because he can't consent to it. But that was his whole purpose for his admission to the hospital, was the LVAD or a heart transplant. And he was there for a week and went into cardiac arrest.
I see.
But then they're saying that I can't consent to it because I was willing to consent early. Like when he went in, I was like, he's here for that purpose. Can I just say yes and you guys do one of the procedures? And then they're saying no. And he called me educated on everything, like on the decisions and stuff, and was ready. But they said that he never actually consented. So.
Okay. Have you or any other family members to this point, have you signed any papers for any procedures? Did you, for example, sign a piece of paper for the dialysis?
Yes.
Okay. So that's a double standard in my eyes, because
that's what I said. That's what I told when I was talking to my mom. She's an attorney, and I was telling her, like, I can consent to everything, but what he was in the hospital for, like, he wasn't in the hospital for dialysis. He was there to get, something replaced with his heart, and they won't let me consent to that. So.
Okay. All right. So I tell you what I would do.
Okay.
I would draft a letter or an email to a hospital executive about this specific issue, and we can help you with that. That's what I would do if I was you.
Okay.
Because you gotta call them out on their double standards.
Yeah. Yeah, for sure.
You gotta call them out on it. Because if you don't call them out on it, they will just do whatever they want.
Yeah.
And like I said in the beginning, Tara, focus on what you can control. Don't worry about, because you'll be not good time of your energy.
Yeah, for sure. You're right.
Focus on what you can control. And
yeah.
you writing an email or a letter to hospital executive and saying, look, why are the rules changing? You asked me to sign consent for the dialysis, and now you won't let me sign consent for the next treatment that he needs.
Right. Which he has even on his advanced directives, he said that's what he wanted.
So that's even documented.
Yeah, he says, like, where the part where it's like, I would like to prolong my life no matter what the costs, like everything he wanted. He said he wanted the extreme, and they, are not even.
Okay. Okay. And you have access to that advanced care directive.
Yeah, that was the POA form that he signed for with my sister and at the bottom of it, he put that, and so.
Okay. So that's good. That's good. I would, and when you write something, attach that advanced care directive.
Yeah. Would you feel that it would be, though, safer for him to do it while on the ECMO, though, like with even as much support as possible, or that really, no?
Yeah.
Okay.
Impeller or LVAD are almost the same.
Oh, okay.
They're almost the same. Right. So I do believe that he will be safe in the short term. Right. He will be safe in the short term. Ideally, he would go onto the LVAD straight away. Ideally, right?
Yeah.
You let's put it that way. Ask for it.
Yeah.
Keep asking for it.
Yeah.
Keep asking for it.
Okay.
This particular hospital, are they a heart transplant center?
I am not sure.
Okay.
They're a big hospital, so I believe so. But.
Right.
Yeah.
Okay. And has a heart transplant been discussed with him or with you, or?
Yep. with him. He even signed a paper saying he would even take someone who's done drugs. Like, he's filled out lots of paperwork. But he didn't inform me about a lot of things until the night before. So, yeah.
I see. So you, for you, there's a lot of new information you need to digest.
Yeah. Well, I mean, I was aware of his heart attack and stuff, but when I went to visit him, as a nurse, I witnessed a lot of symptoms that I was concerned about the night he went into cardiac arrest. And it was just, they kind of were like, well, it's just his, it's just his heart, and it's what happens and stuff. And then he was like, he's struggling to breathe, super anxious, paranoid, taking, oxygen off. I was like, no, something's wrong with him. Then they ended up finding out he had pulmonary edema, and they did that chest x-ray 2 hours before he coded. So yeah, I'm pretty aware of a lot of the stuff. I knew it could come to this and everything, but yeah, pretty close to the last minute that I received all the information of everything. So
Right.
yeah.
And do you know if they have involved the ethics committee at the hospital? Do you know?
Yeah, they did. So,
and
in regards to attempting to disable my healthcare power of attorney.
Really?
Yeah. because they said that me asking about taking him off the ventilator was harmful, harmful to him, or even me trying to put him on Ambien. Just a lot of me advocating is what they're saying is not appropriate. Just another a little secret. I work for the hospital, and I don't think they're aware of that. So I see things I'm probably not supposed to see at the moment, but I could get access to by, of course, pulling his medical records. So I see behind the scenes that they're not aware of me seeing. And yeah, it's just kind of, it makes the situation a lot harder. Yeah. So
right. I see.
That's how I found out ethics was involved. They didn't tell me originally.
Right. I see. A lot of the answers here, Tara, will also, look, ICU teams, as you can see, they're always very good at painting a doom and gloom picture. They're very good at that, right?
Yeah. Mm-hmm.
Which, from my extensive experience, by doing so, they stay in control of the narrative.
Yeah.
What that means is, if your dad is not improving, right?
Mm-hmm.
They can say, well, we told you so right from the start.
Yeah.
Right?
Yeah.
So it's easy for them to keep your expectations low.
Yeah.
Right? If he's improving, I would hope that everyone would look at it and see, oh, well, everyone is winning here if he is improving, right?
Mm-hmm.
But at the moment, they keep your expectations low. I think I've given you the scenarios, best case scenario, worst case scenario.
Yeah.
Right. And there could be somewhere in between, of course.
Yeah.
Just remind me, Tara, how many days has he been on the ventilator now?
Since the 7th, so almost 2 weeks.
7, 13, 12, 13 days.
Yeah.
Okay. So, I would almost argue it's coinciding now with, so the literature suggests that if someone can't be weaned off the ventilator, you should do a tracheostomy between day 10 and day 14.
Okay.
So we are now in that time window.
Okay.
I almost argue it's not coincidental that they're trying to remove ECMO now.
Okay.
Right?
Yeah.
If the impeller is there, it might not necessarily be a bad thing, because he needs other things too.
Okay.
right? And what he needs is some attempts need to be made to wean him off the ventilator, right?
Yeah.
And those attempts can't be made by keeping on the ECMO forever.
Okay.
Or it'll be much more difficult.
Yeah. Yeah.
Right?
Yeah.
Now, the other thing that I haven't seen in your reports is I haven't seen an echocardiogram for a few days, on your dad's reports, I should say,
Okay.
which I believe is one of the determining factors whether they can take away ECMO or not.
Okay. They do it during the turn down studies, and during
Yes.
he's saying that his heart is doing well.
Good. They have not documented that in the reports that we are seeing, as far as I can see.
Okay.
Because one of the numbers you should be looking for in the reports is ejection fraction. I do apologize. My voice is going. One of the terms you should be looking for in the reports is ejection fraction.
Oh, yeah.
Right?
Yeah, he says it's 20%. He said that's what it was before, though. So they're saying it's not improving, but it's not worsening when they turn the machine down.
Right. Okay, so 20% ejection fraction is not great. It's not great, which is why they will be continuing with the impeller.
Yeah.
Right?
Yeah.
He may not survive if they took ECMO off and no impeller.
Yeah.
Right?
Yep.
And ventilation weaning would be so much more difficult if he went off ECMO without impeller. I'd say, he wouldn't improve.
Yeah.
Right?
Yep.
So, to a degree, knowing what I know about your dad, Tara, I actually do believe they are moving in the right direction. But by the narrative they are creating, they're trying to keep your expectations very low.
Okay.
They're trying to keep your expectations at a bare minimum, so that they can, on the one hand, not be the bad guy if things don't work out.
Mm-hmm.
And if things do work out, they can almost shine.
Yeah.
Right?
Yeah.
A lot of it comes down to now, once he's off ECMO, once they stop sedation, is his brain recovering or not? A lot of it comes down to that. But in terms to leverage what you want, go in with the advanced care directive.
Okay.
That's going to be very important, because your dad has no voice at the moment. The advanced care directive is his voice.
Correct.
Is there anything in the advanced care directive that talks about if he was to ever sustain a brain damage? Is there anything that talks about that?
I'm not sure. I didn't read it in the entirety, but I just think it says, like, if you weren't able to, speak for yourself, what would you want? And he picked the most cares, most prolonging options.
Okay.
Yeah.
Well, that removes any ambiguity.
And have you ever in your career ever witnessed, like, somebody? Wow.
What do you mean, like recovering from something like that?
No, somebody who's in a coma receive like a LVAD or like an advanced therapy for their really.
Definitely.
Because I think they brought up ethics when I did try and kind of ask the question. They're like, it would be an ethical issue. And I was like, even though he was here for that, like, that was his whole purpose for his hospitalization. And they
So
yeah.
Here is the issue there, Tara. So let's just say your dad's brain is not recovering to the point that you or your family or he would feel comfortable with.
Yeah.
Okay.
Mm-hmm.
And let's just say the only way to wean him off the impeller once he's off the ECMO is with a heart transplant. Okay.
Yeah.
So let's just say you've got 5 other patients waiting for a heart transplant, and none of them has a brain injury. That's when it becomes an ethical dilemma.
Right.
And that's where the ethic. I have made so many videos over the years. I'm very opposed to what ethics committees are generally speaking doing. I'm very opposed to that. However, when it comes to organ donation and transplants in particular, the number of organ donors is very limited. The number of potential recipients is very high. Right?
Yeah.
Across the board, whether it's a lung transplant, whether it's a heart transplant, whether it's kidneys, liver, doesn't matter, right?
Yeah.
So there is a supply and demand issue, no question.
Yeah.
Right? There's clearly a supply and a demand issue.
Yeah.
A clear mismatch. So if you have 5 patients needing a heart transplant in the next 3 months, let's just say, right? And you have, maybe they can predict, we'll anticipate there's only going to be 2 donors because we looked at our statistics, on average we get 2 donors in a 3-month period, whatever the case may be, right? Chances that someone with a brain injury would be selected are very slim.
Right. Yeah.
Right. But here is the but, as far as I can see. Let's just say, for whatever reason, there might be no mismatch at the moment in terms of supply and demand. Would they let a donor heart go? No, they wouldn't.
Right.
Right. A lot of it also comes down to you got to match blood groups, tissues. So there's a lot of things that need to be considered. I'd say if your dad has sustained a hypoxic brain injury that's irreversible, I'd say chances that he will qualify for a heart transplant are very slim.
Right.
But they're not impossible either because of outliers.
Right. Yeah. Yeah. I'm okay with the LVAD. It just, they're moving towards taking everything and hoping he makes it. And I said I'm not comfortable with that either. So
No. And the LVAD will buy him time and will buy your family time to see what is next.
Exactly. That was my main point. Like, why can't we have time? Because I've done research and seen that sometimes it takes time. And if you have looked at his CTs, it has no findings of an anoxic brain injury. And so we were wanting to do the MRI, but it was just like, even though we're a little nervous, we might have a chance, and we just wanted that time. I understand we can't spend it in the ICU, but if they could just get him stable enough so that we could take him home, and, I would appreciate that. But they're just moving towards no other advanced therapies, and he's just going to have to make it on his own.
Yeah. And, the reality is a lot of patients in ICU don't wake up without a brain injury. They're just in an induced coma. They don't have a brain injury. So from that perspective, it is way too early to see where this is going.
Yeah.
Right. He needs to be completely off sedation for a few days, potentially even for a few weeks, so that you can feel and they can feel comfortable. This is now his baseline.
Yeah. Yes.
Nobody knows what his baseline is at the moment.
Yeah. I agree. Well, thank you so much for answering all my questions.
It's a pleasure. It's a pleasure, Tara.
Definitely an informative video. I hope you publish it for other people,
we will absolutely publish this. Absolutely.
Yeah. People going through this. So thank you so much.
Pleasure. All the best, Tara.
Thank you. Have a good night.
Best to you and your family. Thank you.
Bye.
Thank you. Bye. All right. So I know there are other questions here too Da Vinci says staying on the ventilator will get you dependent as muscles adjust. Yes, absolutely. The double standard is insane. Yes, absolutely. The longer someone stays on a ventilator, the higher chances of deconditioning, right? Muscle wastage, and the sooner, and that's why I keep saying over and over again, if you have a family member in intensive care on a ventilator with a breathing tube or with a tracheostomy, doesn't matter, or even with a mask on BiPAP, the goal must always be to wean them off the ventilator as quickly as possible. Now, there are exceptions to that rule. The exception is that, there are people who will never come off the ventilator, right? Very few people, but it does happen. But assuming that your loved one has a good chance of coming off the ventilator, you must move towards weaning off the ventilator as quickly as possible. Leanne, I need to wrap this up now. I can only go for an hour. I've got a busy schedule. I do need to wrap this up in a couple of minutes. I do another one. I do this every week, once a week, same times. So you will see me again at the same time next week. In the meantime, you can also reach out to us through intensivecarehotline.com. You can book a free 15-minute appointment with me, or you can call me just on one of the numbers on the top of our website. What I do offer is I offer a 15-minute free consultation, and then I do have paid consulting and advocacy options beyond the free 15 minutes, or you can see me here next week again. I do this YouTube live once a week, again, same time. It's 10:30 a.m. on a Sunday, Sydney, Melbourne time, and it is, what time is it for you on the East Coast in the US? I think it's 6:30 p.m. East Coast, 6:30 p.m. on a Saturday evening, Eastern Standard Time, which is 3:30 p.m. Pacific Time on a Saturday, and 4:30 p.m. Mountain Time on a Saturday, and 5:30 p.m. Central Time on a Saturday. And in the UK, it's just before midnight when I do these YouTube lives. So, Leanne, I'm sorry that I can't take you in now. I will need to wrap this up in a minute. Now, if you need one-on-one consulting, if you have a family member in intensive care, go to intensivecarehotline.com, call us on one of the numbers on the top of our website, or simply send an email to support@intensivecarehotline.com. Like I said, I do one-on-one consulting and advocacy over the phone, Zoom, Skype, WhatsApp. We also have a membership for families of critically ill patients in intensive care. And if you need intensive care at home, go to intensivecareathome.com, where we send our critical care nurses into the home for long-term ventilated adults and children with tracheostomy with intensive care at home. We are currently operating all around Australia, in all major capital cities, as well as in all regional and rural areas. We employ hundreds of years of critical care nursing experience combined. No other provider brings that level of expertise into the community than we do. Also, we're also providing level 2 and level 3 NDI support coordination with intensive care at home, and also TAC and WorkSafe case management in Victoria. Okay, yes, Leanne, please reach out to me through intensivecarehotline.com. Doesn't matter whether you're in the UK or in the US or in Australia. I'll talk to you. If you reach out to me, the UK number is on our website at intensivecarehotline.com. Thanks everyone again. Subscribe to my YouTube channel, click the like button, click the notification bell, comment below, and share the video with your friends and families. Take care for now.